reports of aphasia, and at the time there was this possible vegetation on the mitral valve by TEE. That's what the report said. I tried to get the images, and our archive system was not cooperating. Sorry about this. This was left over from the breast cancer comments are left over from previous. She had stage 1 breast cancer, and then she had a left partial mastectomy and a history of hypertension and hyperlipidemia. So in terms of her prior stroke evaluation, she had a CT. This is in 2013. She had a CT that showed a posterior lateral frontal lobe stroke. She had a carotid ultrasound that showed minor luminal irregularities. She also had an MRI, which basically showed the same thing as a CT, which was an acute left frontal CVA. And then she had this TEE, which unfortunately I can't show you the actual images, but the report read a mobile echo density on the posterior leaflet of the mitral valve with mild to moderate mitral regurgitation. And so I saw her just a few weeks ago, and physical exam was, for the most part, unremarkable. Her blood pressure was well controlled. She had no JVD. She did have a loud S4, no edema, good pulses. Her cholesterol in 2012 was, total cholesterol was 249, HDL was 41, and LDL was 168. The most recent cholesterol in 2014 was much better controlled with total cholesterol 139, HDL 40, and an LDL 59. When I saw her this time, a BNP was 22 was normal, troponin was normal. She had a high sensitivity CRP that was 4.3, and that's pretty significantly abnormal. And then I did an ANA test just to screen for some autoimmune condition, and that was negative. And here's her EKG. Does anybody want to take that one on?
Looks to me like a normal sinus rhythm, and everything else looks pretty good. Heart rate, there's some rhythm strip down below, though.
Yeah, so this EKG was done like basically February of this year, and I included underneath is somebody had done a monitor, 30-day monitor thing in 2014. And for the most part, there wasn't any real significant rhythm disturbances, but I included this one strip from that 2014 recording.
So in cryptogenic stroke, you're frequently looking for, in this age group, paroxysmal atrial fibrillation, and so perhaps that's why they did the Holter monitor. And of course, there is this run that's like a 7-beat run, PSVT, and that's all they found.
Yeah. So do you make anything of that? Or?
No, I don't. But of course, I'm concerned about looking for atrial fibrillation, and sometimes one Holter is not enough. Although I don't see any left atrial enlargement on this P wave, and so, and we have no reason to suspect atrial fibrillation in this patient. It certainly is responsible for maybe 30 or 40% of cryptogenic strokes.
Yeah. So here is an echo done recently. Like I said, I couldn't find the TEE, or I couldn't get the actual images. I basically read the abnormalities that were noted on the report. But here's a standard two-dimensional echo. Do you guys make anything of this?
So it looks like the vegetation on the posterior mitral valve leaflet has either been greatly exaggerated or has resolved, and the left atrium's not enlarged. Left ventricle, what I see of it seems to be beating well. The right atrium, right ventricle are not enlarged. We have at the bottom a normal sinus rhythm, heart rate of 74, and so that's about all I can make out of this.
Yeah, it looks like there may be a large PFO or possibly an ASD. I would want to see a bubble study here.
Actually, that's probably just a dropout.
Yeah, they didn't do one on this particular study, but they did back in 2013 when she originally presented for a stroke. They did do a bubble study, and there was no PFO.
Yeah, I'm thinking that's just dropout of echoes at the fossa area because it's thin there. There could not be a significant atrial septal defect in that the right atrium and right ventricle are not enlarged.
Yeah, that's true.
So what do we do now? Anything? Or her current meds are Protonix, Lipitor 40, aspirin 325, lisinopril and hydrochlorothiazide combo, and then she was placed on tamoxifen 20 once a day. So the question is aspirin enough? And then what about the tamoxifen? And then do you think there's any other further cardiac evaluation that's necessary?
So one, I'm not sure aspirin is anything personally for.
Yeah, well, so you have, basically a 45-year-old woman who has a stroke. That's no doubt about it, stroke. And
I think aspirin has been taken guidelines for atrial fibrillation, so I'm not sure.
Yeah, Eric, you keep dropping out.
Okay, hang on. I know she has a little carotid plaquing. That's very common for a 47-year-old lady. And so I guess that's why she's on the Lipitor. And lisinopril can prevent atrial fibrillation. It helps with that. It's obviously for the hypertension. HCTZ is no longer in vogue because it's short-acting, and there's a long-acting HCTZ coming to the market soon, and the other choice is chlorthalidone.
Yeah, so, I mean, at the current time, her hypertension and hyperlipidemia seem to be, well controlled. But she had a real stroke, and the question whether aspirin is enough, I think is still valid. And then if you are worried about something else causing that stroke, she does have hypertension and hyperlipidemia, but whether atrial fibrillation is an important possibility, it may be appropriate to do, some more monitoring. The other thing is about this mysterious mitral valve abnormality. Question of, what would you propose that abnormality was?
Well, that's a tough one without the TEE.
Yeah, so I was inclined to repeat the TEE just to see if there was anything there again. But then let's go back to the tamoxifen. So she's being actively treated for HER2-positive breast cancer with Herceptin and Taxol, and they added tamoxifen to the picture. Does that make sense?
Yeah, what was the rationale for that?
I'm not sure. She has ER-positive disease, but she's being treated for her HER2-positive disease. So there was a paper a while back, but it was a review of all the data that exists. Women with breast cancer who were treated with tamoxifen, and there was an 82% increase in the risk of stroke and a 29% increase the risk, 82% in ischemic stroke, and then 29% increased risk of any stroke, but the overall risk is relatively small. And so in somebody who's had a no doubt about it stroke, in which we are not certain what the etiology is, and I really don't know what the tamoxifen is adding to this picture, that I don't think I would recommend taking it. But I don't know if anybody else has thoughts on that one. Anybody have any comments?
Only that I share your concerns, Dan, but this is a cardiologist, not a breast cancer oncologist.
Right. Well, I was hoping Susan would get on the call, but I did ask her about this case about a week or so ago, and then actually after, I'm sorry?
Susan just said she was muted, but I heard her.
Oh, okay.
I see her as an attendee. I don't see Susan as an attendee.
But I did ask her about this, and then at the time that I saw this patient, I also asked the oncologist what the rationale was for tamoxifen, and he said he was uncertain about whether it should be given or not, and then so I went back to him with that, saying, unless you have a really strong reason, I don't think I would do that in a patient that's already had a stroke, in that we don't really have a clear etiology of it either. I mean, she has hypertension and hyperlipidemia, but a 45-year-old woman with a real stroke is not a great situation.
And what do you think about in aromatase inhibitor for this patient instead of tamoxifen?
Yeah, actually, that's a good question. That's what the oncologist came back with, and I think that's also what Susan said, is that there seems to be a lower incidence of vascular events with aromatase inhibitors. I don't think it's zero, but I think it's lower than tamoxifen. So anyway, I think that seems like it probably would be the best plan on that one. But I think that, I just, for this person, we were being consulted basically to say that if she could tolerate, if it was okay to continue with her Herceptin and Taxol, but actually I don't really think there's much of a concern about that in this particular patient. But the stroke risk I thought was quite significant. But anyway, so that is definitely not an LV dysfunction question, but one that I think for cardiologists of the world is certainly an important one. And my general feeling was to probably repeat the TEE, and then whether to do some sort of monitoring or not. I don't know if that's needed, but if she had any AFib, that would change her therapy. Okay, so a second case, 76-year-old man with relapsed myeloma, and then he's about to start Velcade, dexamethasone, and Revlimid. He had prior bypass surgery in 2014, and his current meds were lisinopril, aspirin 81 milligrams, Lipitor 80, and then Lasix 40 milligrams. His basic labs were fairly unremarkable. His LDL was 84, his HDL was 25, and then his BNP was 294 prior to starting the treatment. And there's his EKG. Have any takers on that one?
Well, sinus rhythm, and he's got a, looks like a Q wave in V2, so you'd read that as a possible septal infarction. Otherwise,
yeah, that's correct. He had a little septal infarct on or about the time that he had his bypass surgery, and he had an MRI done at some point along the way that showed some hyperenhancement in the septum. So I think pretty good evidence that he had a septal infarct there. Here's his echo. Eric, what do you think about this one?
They've already told me he had a septal infarct, but actually, frequently that's usually an apical. So I see in the middle of the septum there's an area that we can't see the endocardium. I'm not sure why that is, but if we're going to look at septal infarct, we'd say apical septal probably on the basis of the EKG. Certainly the MRI is much more specific than an EKG. And so the mitral valve looks fine, tricuspid valve looks fine, right atrium, left atrium, right ventricle all look fine. So it's a matter of a low area of LV dysfunction, and it's hard to track these transmitted echoes in terms of quantifying wall motion. So I would need some more information about that. Mitral and tricuspid valves look pretty good. It looks like a sinus rhythm at the bottom.
Yeah, the mitral valve was, this was probably the best overall image. So without showing you all the other images, but his mitral valve was somewhat thickened, not dramatically so, but certainly above what you would consider normal. That's probably the only other major finding. So he got started on his therapy and his medications. Let me go back. So his medications were, lisinopril, aspirin, and Lipitor, and Lasix. His blood pressure and everything was well controlled. And then about 2 months into his treatment, he had a stroke. And a carotid ultrasound done about that time is shown here. It shows what was read as a 50 to 70% stenosis of his right internal carotid, and then you see the image down on the bottom that, anatomically there's not a really critical stenosis, but there certainly are focal luminal disease in the right internal carotid. So, it was basically read as a 50% stenosis. So the question is, so this is a person that is about to, well, is in his case, he started 3-drug therapy for myeloma, and he had known vascular disease since he had coronary disease already, and he was on appropriate lipid therapy and aspirin, 81 milligrams, and his high blood pressure was well controlled on lisinopril. So all of those things were in good shape. But the problem is that 3-drug therapy for myeloma is associated with significant vascular events. And so the question is should he have been put on other therapy for his upcoming myeloma treatment? So this is a paper that was just published the beginning of March, and the figure sort of highlights, the whole idea about myeloma therapy. How can we prevent vascular events? And so if you look at a patient's individual risk factors, whether their myeloma is, highly active, and then, of course, the therapy that is chosen for the myeloma, whether there is, substantial increased risk of thrombotic events. And in particular, in patients that are on triple drugs, especially including the IMiDs, with high-dose dexamethasone, that those patients are at very high risk for thrombotic events. And so this figure sort of summarizes that. And then under the recommendations, so for patients who are at low risk, then, aspirin is probably adequate. But in patients that are at high risk, then some other treatment should be added. And in this case, this patient was definitely high risk because he was getting 3 drugs. He had a known history of vascular events, and he had multiple other comorbid conditions. So he would have been considered a high-risk patient. So the current recommendations that exist would be that he should have probably have gotten Lovenox or Coumadin. And then there's really no data about some of the new NOACs as far as whether those would be appropriate treatments or not. But the current data that exists would be that he probably should have been put on Lovenox as far as prevention of thrombotic events. So I don't know if you guys have had any experience in this area, but it's a piece that I don't think we address very well, and I think that we need to be thinking about these things. And looking back on that particular patient, I really wish we had done Lovenox or Coumadin, or even a NOAC if that had been appropriate.
So I had a patient in her 80s who had treatment with the thalidomide analog and steroids, and developed pulmonary emboli, and it looked like after the fact, retrospectively, the chances of getting a pulmonary embolus were somewhere in the 80% range, and it looked like prophylactic Coumadin would have been a great idea.
Yeah, and I think that, especially in patients undergoing treatment with multiple drug chemotherapy, then Lovenox was shown to be superior to warfarin in big studies. So technically speaking, Lovenox would have been a better choice. I do think that with the newer NOACs, that whether those would be a better choice or not, I don't know. Ron, do you have any thoughts on this matter?
I mean, everything you say makes a lot of sense. It's hard to know what the incidence is of thrombosis, but I always thought that just really that there is a major risk here, and they need to be anticoagulated with myeloma, and they're on Velcade. And then with these other risk factors, I haven't seen this paper, but that sounds like there's a lot else going on. I mean, you can make a real good case for that. I haven't had any experience with it, though. I mean, I don't see these patients. They don't come to me at that point of their problem. It's always about how's their LV doing, or have they had or something like that.
Yeah, but actually, like in the major trials that have reported on some of the new proteasome inhibitors just recently, like within the past year in the New England Journal and all that, that the rate of PE was, in the range of 20%. And I think the rate of stroke is increased also, but I don't think we know that as well. And certainly I think there is an increased rate of acute coronary syndrome too, presumably due to, some thrombotic event. But the biggest issue is pulmonary embolus, but I do think that, stroke is a real possibility, and I would say in a person that is at moderate or high risk, that you need to go further than aspirin, that's for sure. Exactly what that is, you could debate about it, but certainly aspirin is not going to be good enough.
So, Dan, I'm just wondering, out of all these patients that you see, how many of them would actually be low risk? It seems like there's the bar set pretty low. I mean, the patients on high-dose Dex and Revlimid, already you're looking at higher risk patients alone. So I mean, is there a pretty small portion?
Yeah, no, that's totally true. I mean, these are 65 or 70-year-olds, and they've got chinks in their armor for sure already, and so, and there's this scale called the Corona scale. I don't even know all the details of it, but it's basically risk factors for thrombotic events, and it's like super easy to get a score of 2 or more, and that's because if you have somebody who's getting multiple drug chemotherapy for myeloma and they're obese, then you've got 2 points. And so if they have something else like a catheter in place, or they're going to be immobile because they had back surgery because of their myeloma, any of those other things, then their scores 3 or 4 or 5. So they're all high risk, and you're exactly right.
Has anyone done any trials on this, or is anyone planning on doing any trials to look at anticoagulation prospectively?
Yeah, so this is, I would think that this is like a huge question, and if the rate of PE is in the 20% range for myeloma patients that are undergoing multiple drug chemotherapy, there is no real good prospective data, but we just started, or we're trying to get a trial open at here at Vanderbilt that's called the Cassini trial, and it's rivaroxaban versus placebo in patients that are undergoing chemotherapy. And so I would encourage, if you guys have any interest in these patients and any interest in this question, to see if you can, be a site in the Cassini trial, just because I think it's potentially answering a really important question.
Is it just with myeloma?
No, it's actually not myeloma patients. It's every other kind of cancer other than myeloma or leukemia. So I think that the rate of thrombotic event in myeloma patients is really high.
Yeah.
And so I don't, they probably need to do some sort of placebo study, but I'm not sure that anybody wants to do that one because they feel like they need to do something, and a placebo is not good enough.
Well, even a NOAC against Coumadin wouldn't be so bad in this.
Yeah, I would actually say that would totally be the study that I would do is a NOAC versus Lovenox, or a NOAC versus warfarin, or a NOAC versus both. But, I don't know if the NOAC companies are prepared to do that or not. So I think that if there is, if you have any chance to consider being part of the Cassini trial, that would be great. And then the other is, especially in patients that you may happen to see who have myeloma, that I would just absolutely put on your radar that these are high-risk patients and we need to have a better anticoagulation strategy.
Yeah. It's a good paper. Some interesting third and fourth authors in this paper.
Yeah. So that's all I got. Thank you guys so much, and I think.
Where do you find out about the Cassini trial? How would you go about looking into it?
If you have an interest, what I would probably do is I would send the trial, leadership, your name, and ask them to contact you if you want to do that.
Just Google Cassini. You'll get a monastery in Italy, I think, or casino.
No.
World War II battle, isn't that it?
I don't know about that. Here, let me.
There was a Count Cassini trial.
No, it's.
That trial was actually a trial by jury.
This, it is. Let me see if I can. I can send out the clinicaltrials.gov thing for the exact details.
Mm-hmm.
But the sponsor is Janssen, since they make rivaroxaban.
Mm-hmm.
And the study is just now getting started.
Okay, we'll look for Janssen. Thanks.
Apparently it's a multi-center study led by Dr. Khorana, Khorana, called the Cassini trial. Something to do with the Cleveland Clinic?
Yeah, I don't know about that. If you're looking it up, yep, that may be the case. It's definitely Janssen is the main sponsor. So,
trial apparently has to do with NIH.
All righty. I appreciate you guys joining in.
Thank you, everybody, for coming. Dan, thank you for your presentation. I want to thank Arjun, Barry, Brian, Calvert, Carranza, Maria Santos, Ron, and Sebastian. Thank you, guys, for coming. Appreciate it.
Great.
It's always
Thank you. All right.
Thank
Thanks
you.
a lot.
Bye-bye.
Thank you. Bye-bye.